Jignesh bhai, can we go live now? And just tell me.
Yes, started.
Good evening. I am Dr. Omkar Swami on behalf of metpure Pharmaceuticals Limited. Welcome you all in this workshop series organized in association with International Course of Excellence. Expert Connect is a live recorded case series of real life vascular interventions and imagings by very renowned interventional cardiologists of the country. Today we have very eminent panel to discuss two interesting live in talk about live recorded cases at real life scenario. Please join me welcoming Dr. PC Rath sir and Dr. Samir Dani sir, who will be presenting two very interesting live recorded cases today. I also welcome Dr. Raju Menon, who will be the moderator for this program. And most importantly, let me welcome Dr. Professor N.N. Khanna sir, who will be course director for this program. I sincerely express gratitude towards Professor Dr. Khanna sir, who have developed this program and who was instrumental and soul and brain behind developing this series of workshop. So this will be a 4 series of workshop with involving a very senior interventional cardiologist of the country. So Dr. Professor N.N. Khanna sir would be a course director for this workshop series. We all know sir is a group advisor of Apollo Group of Hospitals in India. He is a senior consultant and coordinator of cardiology and cath lab. He is a past president of our Indian College of Cardiology and past chairman of Cardiology Society of India. He is currently serving as a chairman of National Interventional Council and chairman of Asia Pacific Vascular Society. Sir is president of International Society of Endovascular Specialists of Indian chapter. Sir has been on editorial board and a reviewer of many prestigious journals like JACC, American Heart Journal and Indian Heart Journal. Sir is currently working as a Governor Council member of various cardiological societies of India and International Society of Endovascular Specialists of USA. Sir is currently director of World Federation of Cardiac Imaging and Clinical Cardiology. Sir, thank you very much of being as a course director, and I'm sure under your leadership, this workshop series will be a great success and will address to the needs of the interventional cardiologists of the country. Thank you very much giving us an opportunity to associate with International Course of Excellence and this certification. Now with this, I hand over this session to our course director, Professor Dr. Khanna sir, and beg your pardon. Thank you very much.
Thank you very much, Dr. Omkar. I'm going to be straight away going to the start of this session. Let me introduce you before we start Dr. PC Rath. Dr. PC Rath is the chairman of cardiology at Apollo Hyderabad, and he is one of the key pioneer figures of interventional cardiology in the country. And he's been instrumental in training hundreds of interventional cardiologists, part of country, but in the entire country. I hope I am audible or okay. So he's going to be talking about left main bifurcation stenting. He's been a senior consultant and head of cardiology at Apollo Hospital, Hyderabad, has 35 years of experience in cardiology, and is a visiting interventional cardiologist at University of Rouen, France. Samir is a very close friend. Dr. Samir Dani is chief cardiologist at Apollo CVHF Heart Institute, Ahmedabad. He is the director of cardiology services at Apollo Hospital, Gandhinagar. He is honorary cardiologist to His Excellency, the Governor of Gujarat, and he is the former professor and chief of Department of Cardiology of the prestigious UN Mehta Institute of Cardiology and Research Center, Ahmedabad. My other colleague and a close friend is Dr. Rajiv Vijay Kumar Menon. He is a cardiologist at AIG Hospital, Hyderabad, and is an ex-visiting faculty to TCT Interventional Cardiology Forum and ex-visiting faculty to TCT Interventional Cardiology Forum of USA. And he's been faculty in the World Conference on Acute MI Primary Angioplasty, the Global Lumen Conference. So with this, I will actually ask Dr. P.C. Rath to start the session. And after near the end, I'm going to be taking you through what we are going to do in this series of 4 lectures. Four live case lectures, where we'll have a set of 2 eminent interventional cardiologists discussing their live inbox cases. And I will be giving you the full agenda and along with and probably at the end of the session. So let's go straight to Dr. P.C. Rath.
Thank you, Dr. Khanna, and thank you, Dr. Omkar, for arranging this beautiful seminar, webinar, and my friend Rajiv Menon is there, and also we'll be hearing from others, all the speakers. But I'll be speaking on left main bifurcation stenting and using imaging technique. And I've got a very interesting case for you. This is a 49-year-old male, non-diabetic, non-hypertensive. He was a chronic smoker, presented with unstable angina, and we took him for angiogram. This is what he has: very, very critical left main bifurcation stenosis, and it's localized to left main bifurcation only. RCA is normal. You can see this in another view. Very, very eccentric, critical left main bifurcation stenting. So he was given the option of surgical and percutaneous interventions options, but he was very young. He was not willing for surgery, so he decided to do percutaneous interventions using stents. If you look at this bifurcation, angle is around 40-50%, 30-50 degree, and with size of the vessel angiographically is around 3 plus LAD, and the L6 was 2.5. So we thought we'll use a 2-stent technique, and we decided to, because of less angulation, we feel decay class will be ideal for this patient. So what we did, we took a 7F catheter, guiding catheter, put 2 wires, one in LAD and one in L6, and dilated the. Before that, we did the OCT first to know the size. Dilated the LAD first. What is that? OCT picture. Just
hear properly. It is like is it everybody, doctor, problem at the side or on my side?
Just
are you able to listen to me? So let me just change the network. Okay, so I'll be like and then you'll be on the line.
Yeah, just can you?
A minute and let me change that.
Give me 1 minute. There is some problem here. I'm just trying to set it right. Just wanted to show you the OCT picture before the interventions and just show the LED picture. What happened? Before that, OCT, I wanted to show the we did the OCT first before we calculated the size of the left main, which was around 4.5. LAD was around 3.5. And what we did is first we dilated the LAD with using a 2.5 12 millimeter balloon. And after that, we did the OCT. You can see there is balloon-induced distal dissection of the ostium and a lot of thrombus, which was not seen in angiographically, but a lot of thrombus in between. So we decided to give glycoprotein 2b3 started immediately. After we pre-dilated the circumflex using 2.5 12 millimeter balloon. After doing this, we stented first L6 using 2.5 18 millimeter stent, which was protruded into the 1 to 2 millimeter into the left main, and we had already put a balloon in. And after that, your internet connection has to see. After that, we crossed the L6 stent with a 3-in-12 balloon. And same balloon we used to do a little pot also, which is not shown. And after that, we recrossed the L6 stent using recrossed again. And after recrossing, we checked the OCT just to see that whether we have recrossed proximally. Ideally, you should recross proximal in the proximal cell of the stent. So we checked the OCT. You can see it very clearly that this wear has crossed from the proximal cell of the L6 stent. And once we checked that, then we went ahead and what we did is we dilated. Hello. After that, we did the first kiss and dilated the strut of the first. We dilated the strut of this stent and put a 3-in-12 2. With a 3-in-12 and 2.5 12, we did the first kiss. You can see this. After the first kiss, we pulled out both the balloon, pulled out the wire from L6, and put a stent from LMCA to LAD 3.5 18 stent. You can see this. We dilated up to 14 millimeter with this stent, left main to LAD. We crossed the circumflex stent also. Am I clear? Can you hear me?
I can hear you.
Okay, fine. So this is the second cross, and after that we did the pot using a 4-in-12 balloon, and pot we did it keeping it in the inside the stent, the left main, and just near the carina, up to the carina. We did a 4-to-12 balloon for pot, and this will make it easy for us to recross again. And that's what we recrossed again, and using one more wire, and we cross-checked by OCT again. You can see that we have recrossed again the proximal cell of the stent. There are two stents, you remember, in this position, so it's a little difficult to cross it, but we recrossed it, and we checked with the OCT that we were sure that we were in the proximal part of the proximal cell of the stent. So this is the OCT. That's how it helped. The OCT helped in this situation. After that, this also in 3D OCT we reconfirmed that it has been recrossed in the proximal part of the cell of the stent. After that, we took a small balloon and dilated the strut of the circumflex and put a 2.5 12 balloon in the circumflex and 3.5 in 12 balloon in the left main to LAD, and did the kissing. You can see that kissing, and the end result angiographically looks very good, and this is the kissing. After that, you can see the end result, which angiographically looks excellent. And after that, we did the OCT, and you can see the metallic stent optimization. We saw in the proximal part basically to see the stent is well approached to the left main. You can see the white struts. That means the stent is well approached to the left main. We saw the other stent apposition, the LAD and circumflex also, LAD mainly, that was perfect. And after this, we're confident and the stent, both stents are well approached and there is no distal resection, there is no other problem, and we concluded. And in this case,
कनेक्शन लॉस हुआ क्या? हाँ, कनेक्शन लॉस झाला.
We can't hear Dr. Rath right now. Hello? Hello? Mr. Swami?
Yeah, I think we lost the connection with this, sir.
Okay.
you can cross the right, cross the guide wire in the proximal part and stent apposition. You can see it, which you can see and demonstrate that it's well apposed or not. Thank you very much.
So that was a very interesting case of OCT guided left main stenting, bifurcation stenting. I will leave this for discussion. Samir and Dr. Menon, would you like to join in and take the questions? And ask if you have some questions, ask Dr. Rath. Then I have a series of questions here, which I'll be from the audience, which I'll be asking later on. So over to you, Dr. Menon and Samir. So, I believe Dr. Menon and Samir are just hooking in. Dr. Rath, what will be the difference between the proximal, wiring and a distal wiring? How will it make your stenting procedure easier or difficult, and in terms of optimization of results?
Mainly, if you put, if you do cross to the proximal cell, then you don't distort the carina much. And this stent covers very well majority part. But if you cross distally, the chance that some of the areas will be missed, and also the carina will be distorted. So ideally in this situation, proximal crossing is the best. That's the important thing. Both first and second time, you should try to cross proximal.
In that case, if you go distally, you need to come back and rewire to the proximal struts. Is that your strategy every time?
No, you are doing, ideally you should go distally and pull back, and then it will be, then you can go to cross proximally. That's the technique. You pull the wire and then cross proximally. And whatever you may do, but angiographically is very, very difficult to be 100% correct that you have crossed proximally and all that. For that, you really need some imaging. The best is OCT.
So that my question again is, in case you go you have crossed distally, because angiographically you don't know, do you take back your wire and try to recross?
You can. If you are using OCT, mainly OCT is used to see that you cross proximally. If you have seen that you have gone distally, and then you can use one more wire and cross proximally, or you can pull out the same wire and go distally and then pull it back again. Either of them. If you are confident, sometimes you are not confident that whether you will be able to recross or not. In that case, you can leave that wire, put one more wire, and then recross again. So these are the two techniques used.
I've got
But,
questions. This question is from Dr. Vilas Magarkar from Aurangabad. And the question is, please explain why you didn't use a cullet technique here.
no, you can use cullet also, but I think that first is size, these two vessels size disparity is there. It's around 3.5 LED is 2.5 is the circumflex. That is the main reason. And some studies have shown that definitely result of decay cross is better. It's a very limited study, but definitely they shown. So both can be used, but because of the size disparity, I prefer to use this decay cross, and there is some evidence to show that decay cross results is better than cullet also. That's the reason.
Another question from Dr. Gunjan. If we do not have an OCT, how to make sure whether you have crossed the stent proximally or distally? The proximal stent.
If you try to cross proximally, hope you have crossed proximally angiographically.
So there's no other way to actually know. I think we have lost Dr. Rath again.
Yes, yes, yes.
Okay, so Samir and Dr. Menon can take the question. There's no problem. Samir, are you audible? Yeah. So Dr. Sanjay, what wire would you use for recrossing?
Way angiographical technically, you have to go distally and pull it back and then try to cross proximally. And hopefully it has crossed proximally. That's what you aim. And probably you may be able to cross, but when there was without imaging, it's very difficult to confirm whether it has gone proximally or distally.
So there are two people who have asked, did you do a pot after the final kissing balloon in the left main?
Yeah. That is that I didn't show it. That is should be done. That pot after the kissing, I didn't show that pot, but it should end with pot. Actually, 3 times pot is ideal to be. First stage before, after doing the putting the stent in the circumflex before crossing, you should do pot. Second pot is before recrossing second time with the wear. Third is you can end with the pot. Because that is the...
Yeah, I'm sure. I mean, every time if you are doing a left main, you have to end with a pot to the left proximal.
Yeah, end with pot. That rule.
And Dr. Sri Chandran, he has a question again, how to decide on balloon size and whether your balloons were non-compliant balloons, the NC balloons.
We used all non-compliant balloon, and regarding the what sizing. Size we have.
How do you size them?
Size is 1:1, 1.1 to 1, and for the kissing, it should be around we have used in this case 3 and 2.5. Size of the LED vessel was 3.5, with 3 and 2.5. It should be 2.5. Vessel of the left main was around 4 or 4.5. So 3 and 2.5 will be around that. Roughly that will be the diameter.
Dr. Sanjay has a question. Sometimes routine wire like Renato or run-through do not recross. So do you use CTO wires like Pilot in these cases?
Yeah, it can be, but I preferably use all this where the builder whisper is the... Every time I want to recross, I usually prefer a whisper because it's just slide through. The setting is more technically difficult with which is I got
Samir, what would your strategy be in such a patient? You know, you had a patient like this with left main bifurcation. How would you treat it? Would you treat it differently from what how Dr. Rath did it? And suppose you do not have an OCT, what would your approach be then?
If I do not have OCT or IVUS,
If you don't have both, what will you do? And if you do not have OCT but have an IVUS, what will you do?
IVUS is fine. I'm comfortable doing it with IVUS. In fact, more so than OCT because of the simple reason that we don't have OCT all the time. So we have IVUS all the time in the lab. So I'm a little bit more comfortable doing it with IVUS, and then because that's how we learned. But I agree with Dr. Rath that OCT seems to give better comfort and better images as far as such small things which he said are to be seen. My approach would have been pretty similar. And one word of caution about the wire which you want to use while recrossing. Dr. Rath is an experienced cardiologist, so he can manage. But for youngsters, I would say that try to avoid very slippery hydrophilic coated wires because they can slip through the struts very easily between the vessel wall and the strut. So if you have not post-dilated very well and your wire goes behind the struts, that can create a problem for you. So always try to use the routine wires first, and then if they don't work, then you use hydrophilic wires like Whisper or Pilot, but be careful, especially initially because those wires have tendency to slip behind the struts.
Is Dr. Menon with us, or Dr. Menon has he joined?
No. He has not yet joined us.
He was busy with some other meeting.
Yes.
I think.
And there's a question again, Dr. Rath. What pressures do you use in this kissing balloon?
12.
So is that like 12 is your favorite
Yeah, there's
number,
one
or
is sometimes first we do it's the side branch. I first dilate it with 18 and then simultaneous kissing with 12.
There's
Initial
another one
kissing
from
with the
Dr.
side
Rizwan. He says your left main was 4.5 on OCT, but the pot was done with a 4 millimeter balloon. Was there any reason for that?
Yeah, actually there was 4.5 was not there that time. So we went high pressure with 4 and that's the only reason. But we did the OCT which shows that the stent is well opposed. That's the reason. I would have preferred to use a 4.5, but that time it was not there. So with 4 I went higher.
But an NC 4.5, I mean 4 would not grow to 4.5. It will be less than 4.5. So practically,
it's less
used in stent was the pressure which was, you couldn't oppose that further.
It's there, but you know what happened? We have this kissing, we have put it in the left main. So that also has expanded the left main stent by 12. So in the end, we did it with what we did it for, which is not the ideal thing. But we would have, if OCT would have shown that it's not well opposed, probably we would have thought something else. But OCT, it was very clear, it's well opposed. So I didn't want to again look for something else.
It's okay if you have a small left main like 4.5, maybe up to 5, but anything above that, OCT loses its value. I think again it's the intravascular ultrasound which scores over it on a bigger left main. What are your comments? Because you know I like doing with OCT, but when it comes to left main and the big left mains, then OCT has their own handicap.
Yeah, most of the I have switched over to OCT in most of my left main interventions because that gives more informations, and except the osteal, of course, or in the patients who have severe LV dysfunction or renal dysfunction. Otherwise, most of the cases of left main interventions, I'm using OCT and not intravascular ultrasound.
Most of the left mains in your place are around 4.5 to 5.
Around 4.5, and it shows very clearly the OCT. There's no problem.
4.5, it's okay, but anything above 5, 5.5, it has a limitation.
That is, yeah, 4.5 is okay with OCT, 4.5 to 5. But beyond that, it's not ideal. Beyond that, I think intravascular ultrasound is better. But most, that is the rare things.
Because, you know, when we do these patients, especially at our place, what we have seen, many of these patients do have a significant renal compromise and sometimes an LV dysfunction.
Yeah, these are the cases.
What we use here is, you know, sometimes it takes so much of a contrast. So we've seen if we flush with dextran, it actually works very well, and I've used it like twice, once in a life case. Dextran really works well, and it avoids the need of the contrast. Samir, any idea? I mean, any experience with this in your case?
See, I have tried this dextran. It was not very clear. So I'm not very happy with this. But people have been using this dextran, and some people say that picture is very clear, but I'm not very confident about it. So that is the other way of in patients with renal dysfunction, severe LV dysfunction, you can use that. But I feel that if you are not using OCT because of this other renal dysfunction or severe LV dysfunction, maybe we should switch about to intravascular ultrasound. That will be better than dextran and all these things. Dextran people have tried. I've tried one or two cases, but it's not very clear. So I don't know about your experience, but
we have started using dextran. I don't find a lot of issue with imaging. It gives a reasonable imaging. I mean, I found it to be quite okay. Now, Dr. Rizwan seems to be getting a lot of questions from you. You know, he says, why kissing balloon with 3 millimeter in LED stand, which was 3.5 millimeter? Won't that
can you repeat it
towards LED?
Can you repeat the question? It's not very clear.
Why kissing balloon was done with 3 millimeter balloon in LED when the stent was 3.5 millimeter? Won't it shift the carina towards the LED?
It is not necessary that you should, when you use the kissing balloon, you should size it according to the same of the vessel, because you are using two. It's not. It's preferably one of these will be little less than the actual size of the vessel. So it is not recommended that one.
One would actually oversize.
It is not.
So it's always 0.5.
Yeah, overdo it.
Less. Yeah, I agree.
Yeah, it will be less.
Two balloons there.
Yeah, one should be less.
Okay, so if we are done with Dr. Rath's case, then we can go to Dr. Samir Dani's case. Samir, are you ready with your case?
Yes. Sure.
So, over to you, Samir.
Is it visible?
Yeah, quite well visible.
Okay, so I have compressed kind of 4 cases into this talk. I'll try to show you 4 different cases with a little bit different strategy. So as you know, around a quarter of all patients with coronary artery disease have moderate to heavily calcified lesions, and this is going to increase because of various comorbidities. The treatment of heavily calcified lesion incidence is going to increase in PCI. Rotablation has been the predominant technology for all of us for treatment of these calcified lesions. There are new technologies coming up. We have been in past using NC balloons, high pressure balloons, cutting balloons, angiosculpt, even laser has been tried. Rotational atherectomy is the mainstay. Orbital atherectomy is another one. And what I'm going to show you is with the shockwave therapy. This first case, 78-year-old female, hypertensive, came with acute coronary syndrome, and STEMI, went into shock but quickly recovered with tirofiban on board. And her angio showed left main with triple vessel disease. As you can see, LAD was the only surviving artery. Circumflex totally occluded. You can see the right coronary also filling up. That was also totally occluded. Severely calcified arteries, especially the left main in LAD, and as I said, the only artery. And here we feared that she wouldn't tolerate rotablator very well, and the family was also, and we had this shockwave therapy just new in, so we decided to do the shockwave therapy. With a lot of difficulties, we got the balloon in. We had to dilate with a 2.5 millimeter balloons, make the way for shockwave, and with the new balloon and about 8 pulses, the waist did disappear nicely. And we were able to put in a long stent. Post-dilated it. And she stabilized. This was the first use of shockwave in left main in our country. Very new technique at that time. This was just in January. The second one, 86-year-old male, not diabetic, normotensive, but had acute kidney injury. After stabilization, his angio picture was something like this. Here we did the circumflex, which was not so very calcified, so we quickly did that, and then decided to do the rota. You can see that LAD was badly diseased from the ostium. Very slow rotablation, followed by good balloon dilatation. The lesion cracked open at 10 atmosphere after the rota. A long stent from the ostium. In this case, since it was a very short left vein, I had no choice but to put the stent precisely from the LAD ostium. We did IVUS and OCT both in this case. At that time, we were doing this case live. Third case, 70-year-old male, not diabetic, but hypertensive. He had angioplasty to OM and RCA in 2013, had bilaterally aortoiliac stenting also, had unstable angina. He was attempted elsewhere and came to us, had lesion, the circumflex artery, that appeared to be the culprit lesion. LAD didn't look like the culprit vessel, though had significant lesion. Quickly did that, and then decided to do the circumflex. After crossing with a lot of difficulty with the wire, just like my another colleague of mine who had attempted the PTCA previously, we could not pass a balloon, we could not pass even a fine cross over this wire. We tried dilating the proximal segment. When I took the fine cross out, finally, the fine cross tip came off. You can see it on the gauze piece. Then I crossed with the rotablator wire directly and did the rotablation. Then we could cross into the OM also, which was a culprit vessel. And stented. The fourth case, calcified proximal segment of the LAD. The lesion itself did not appear to be so calcific, but what happened? We made way for shockwave balloon. Went very well, it seemed so. Then we could place the stent also easily. Then we realized that stent had not fully expanded at the original lesion spot, in spite of shockwave being used. We did IBUS, found that stent expansion was not perfect. We had no choice but to use opiate balloon. Opiate balloon cracked the lesion, expanded the stent at 40 atmosphere. Then we got this kind of result. So I think the problem of heavily calcified coronary lesions is going to increase in future because of aging population, increased rates of diabetes and chronic renal disease. And it's very important that we have to have working knowledge of multimodal imaging techniques and the use of various devices, as the case may be. Rotablator, rotational atherectomy, and shockwave intravascular erythropoiesis are two modalities. And third one, to my mind, is opium balloon, which can be used to treat these complex, heavily calcified lesions. Thank you.
So Samir, those were very interesting cases, and it's a very clear demonstration, of different modalities of rotablation, of high pressure balloons, high pressure balloons, opium balloon, and also now the shockwave leucoplasty. So those and many a times we have to do a combination of this because of medical reasons, and also because one technique is failing in the other may be more important later. So let me, Dr. Menon has not joined, so maybe Dr. Rath, if he has a question to ask, or otherwise I'll start setting the ball rolling.
See, in intravascular lithotripsy, when you use it, the catheter is bulky, so you have to use first make the passage, and many times it is in very heavily calcified lesion. It's really difficult to make it. So many times you can end up going for rota. So that's the limitation of intravascular lithotripsy. And you have demonstrated very nicely these two cases. But there are cases where the lesions are very heavily calcified and very tight. And after balloon dilatation also, you may not be able to put the intravascular lithotripsy catheter. And what about your opinion, Samit?
Yeah, I agree totally. And as I showed in the third case, hello, am I audible?
Yeah,
Yeah,
you
yeah.
are.
So as I showed in the third case, no balloon would go in. I knew this, that my previous colleague had failed, my another colleague had failed. So I was ready with everything this time, with rotablator, with fine cross, with imaging modalities, with shockwave lithotripsy, everything. Nothing worked. So even the fine cross would not cross, would not go through the lesion. And then I had to rely on rotablator. Once the wire went in, after a lot of struggle, finally the rotablator wire went in, and then it was kind of easy. So, in the fourth case where we thought we had cracked open the lesion with shockwave, we thought that everything was rosy. We were done in like 30 minutes, and then we realized that the stent had not expanded properly, and then that lesion just would not give way. Then, luckily, since we had OPN balloon with us, we could crack it open. So, I think we have to kind of mix and match our strategies. And you are very right that shockwave has a bulky catheter. So every time you may not succeed in crossing the lesion.
Samir, I would sort of now suppose you have all the technologies and you have say a case. How do you choose between a rotablator? How do you choose between a high pressure balloon and a shock plastic? Everything is available, and all the imaging modalities are available.
I think from perspective of simplicity, I would choose shockwave because it's very easy. It's like a routine angioplasty. You just go in and inflate the balloon, and it takes care. It's magical. But we have to be aware that there are times when you won't be able to deliver the balloon there. That's the only thing. So if money is not a constraint, if all the modalities are available, then probably shockwave would be my first choice. But if I feel that it's going to be a challenge to deliver shockwave, then I would start with rotablator first, because it's very important to note here that if you have tried ballooning the lesion to deliver the shockwave balloon and still you fail, if you fail, then you have no choice but to continue to balloon dilate with higher pressure balloons to deliver shockwave. You can't do rotablator because you have already done some damage. I'm sure some of the colleagues, some colleague would have had experience of using rotablator after doing ballooning, but it's all sometimes very messy, and you can get into problems. So I would rather close the case, come back a few days later.
Yeah, I agree. The other problem with shockwave, I mean, we use it a lot in our center, not for coronaries, but for peripherals. You were the first one to do that. Similarly, in coronaries, if you have multiple lesions and long lesions, you may end up using one or more than one balloon, and each balloon is very costly. It has a fixed number of pulses it can deliver. So that's a real challenge, for if you have 3 vessels and all 3 calcified and long lesions, you may end up using 2 or 3 balloons, and that itself would be a cost of 5 lakhs or something. And definitely, you need to first have enough space for the balloon to go in. And I find it's good for eccentric, better for eccentric calcium than concentric calcium. And it's pretty, the good thing about it, that the risk of rupture is very low. It's hardly there, it works. So, it's very hard on the hard lesion, but very soft on the soft part of the vessel. So it's a very low chance of perforation. And actually, as you said, it is like, you see a simple balloon dilating serially, and it sort of prepares the vessel very well for further dilatation and putting in stents and good standard expansion. But before that, I would ask both of you, all of us have seen heavily calcified vessels on angiograms. Many a time our technicians would say, oh, don't do anything, just take a balloon and, you put in a stent, and we think it is not going to work. But many, many, many times it works. You just put balloons and you dilate and you put in a stent very easily. But sometimes you find very little calcium on an angio and you look for it very precisely, especially in concentric lesions and tubular lesions. You may end up using 5 or 6 balloons. You may not be able to dilate those properly and put in a stent, and you can never expand the stent very uniformly. So what is your practical, approach? How do you, do you work by intuition? Because I agree totally with what you say. Once you have ballooned it enough, you don't then try to take a rotablator and rotablate the lesion. You need to wait. And sometimes it's not easy and advisable to wait, because the arteries may actually close out if you're not putting a stent properly and you're not able to expand them. So how do you sort of know whether the calcium is, luminal, intimal or subintimal or adventitial, and what technique is going to work on an angiogram and also on, the type of OCT?
I think, Dr. Rath, you want to go first?
I can hear you, but I'm not able to see your face.
Okay, but we can hear you. We can hear you. You can talk.
Yeah, Samir just wanted comparative study result between intravascular lithotripsy and rota. You have something? Tell us.
Not really. We don't have really unbiased kind of a trial, because it will be very difficult to do. But the shockwave results have been pretty encouraging. So, and the crossover rate has been pretty low. There are case reports where they have done rotablation to get the shockwave ballooning. So after, say, doing 1 point with a very small bar, they have done the shockwave balloon. They've taken the shockwave balloon in and done the shockwave lithotripsy. I personally can't imagine many cases where you would like to do that, because of the cost involved, and because then you can just upsize the bar, do little more burring, and if the patient tolerates. The only reason why you would do that, when you think that rotablator patient will not tolerate rotablator, or when you are doing something like bifurcation where you can't use rotablator very effectively.
Basically, the complications rate seems to be less with intravascular lithotripsy. That's the beauty of this new device. And once, as you told, once you deliver the catheter, it's like any other balloon angioplasty, not like rota and all the complications with it. Beauty is in simplicity, and I think less complications.
Again, Samir, I'll come back to the same question. How do you intuitively decide angiogram? How do you decide which technique to go in first, and what would work? Because on the table, many a time we are fooled. We sometimes think the lesion is so simple, we'll come out and we spend hours to actually get a good optimal result. And sometimes we think we're going to have a real trouble, and we come out very fast because the lesions give a very
tell you scientifically, we all look for adventitial calcium. We feel that the calcium is adventitial. You try to go ahead with the balloon on angiography, but it is very difficult to. Sometimes it is very apparent that the calcium is adventitial, but not always. Second thing is, I mean, you get fooled many times. You feel that it is less calcium, and you go in and you find that there is one spicule which is holding your balloon back, ruptures all your balloons, and just does not give way. So it's very difficult, number one, to really be sure angiographically. Number two, there are times when we have examined, our own use of pattern of use of rotablator in past. It was very interesting. Once you open, once it happens, like what you said very correctly, that your technician says, "Come on, sir, let's do it." The patient doesn't have enough money. You go in with a balloon, the lesion cracks open, and you are surprised because you felt that this lesion is not going to crack open. Once you do that, typically next 3-4 cases, you tend to try the balloons more. This is the pattern we observed in our cath lab in government institute. Then you try more, and once you fail and you get into problem, then again you start using rotablator more as a more preferential technique. So that is very typical. Personally, I would tell you very honestly, if the patient has money, if rotablator is not a problem, I would go in first with rotablator because I wouldn't like to get stuck where the lesion doesn't open. Then you're dilated with high pressure balloons. Your artery is bleeding, is in a mess. Your flow may or may not be good. You need to stand, but you can't stand because the lesion is not opening up. And then it's a big problem because then you have to sometimes leave the case there, restore the flow. I mean, hope that the flow is restored and will remain like that. Bring the patient back after a few days once the artery has healed. Sometimes it takes weeks to do safe rotablator. After angioplasty means taking maybe a week or 2 weeks off and then bring the patient back for rotablator. So all that mess is saved if you choose rotablator early on. So I would err on the safer side, do rotablator or shockwave, rather even when little less likely, even when there is some likelihood of opening the lesion with a balloon, and get the case done with more surety.
I would also say you have a calcium, on a bend and it is eccentric, so you will always tend to have a rota bias. In those sort of situation, EVL would work very well.
Correct.
And it will really be a very good technique to use a lithoplasty balloon, and it will take care of that eccentric calcium on the bend. And that's one of my indication. Also, again, if you have money, we go for these devices. Otherwise, we tend using high pressure balloons and tracking and then putting a stent. Now, between the OCT and IOS, how would you sort of, what would you prefer for imaging the calcium? Because both are good techniques and both would have a different picture on imaging. Which is your preference and why? And Samir and Dr. Rath, we have more than 1,500 people who have already logged in and they're watching this. So it's quite an interesting conversation. I've got a series of questions here. So how would you choose between an OCT and IOS to define the calcium and strategize your treatment plan?
I'll go first here because I have less experience with OCT. So let Dr. Rath have final word on that. I personally use IVUS little more, and in these cases, I would be little more comfortable with IVUS because most of these cases have they are these very heavily calcified lesions. They are older people. They are heavily diabetic. Many times they have CKD. So contrast volume is a big issue. And with OCT, you have to inject significant amount of contrast. Here you are trying to do the angioplasty with 50 ml of contrast, and then you suddenly, with one OCT run, you have to inject 710 ml. So that is one reservation I have about OCT. And again, the calcification, the stent expansion is very well seen with IVUS. So OCT, to my mind, is kind of a number 2 in these arteries. But again, I have a bias because we have a little less access to OCT compared to IMS.
Dr. Raj,
Look at the imaging quality. If you want to see really inside and decide on this, that OCT is definitely far superior. But only problem with the OCT is in these heavily calcified vessels, many times you will not be able to track the OCT catheter down. That is the only technical issue. But if the catheter goes, and if you want to see the inside of the arteries, decide for yourself what is to be done, then quality-wise, OCT images is far superior regarding calcification, all these things what you're looking for. But only technical issues, not many times, sometimes it will find it difficult to track the OCT catheter. The OCT catheter and very delicate. This calcium will not allow it to get it. Many times we do it after doing balloon dilatation. And the depth of the calcium you can see better with the OCT.
Arvind has a question to Dr. Sameer. What is your advice about a heavily calcified tortuous vessel with an aorto-osteal lesion? How would you approach such a patient and with which technique?
Very tortuous vessels.
Also aorto-osteal.
Sorry?
Very tortuous vessels, heavily calcified, and also aorto-osteal lesion in combination with aorto-osteal lesion.
I think all these cases would be, with rotablator, I would be very nervy and jumpy while doing these cases. I would, to my mind, shockwave would be the first choice in these cases. If you have aorto-osteal lesion, or if you have a tortuous vessel where you are not sure of doing your rotational atherectomy very cleanly, then.
But what about the other devices like cutting balloon and all this for aorto-osteal lesions?
Absolutely.
I prefer to use that.
Aorto-osteal lesion, if they are standalone, or if you are the cutting balloon is a very good choice.
Yeah, so again, it will be like I don't know whether we can use a cutting balloon and also IVL after that, but I think it should work because IVL actually works only on calcium. And I believe more complex the lesion, and if you want to simplify your strategy, if you can get in an IVL and patient can pay for it, I think it works very well. The learning curve is hardly any, so you can learn how to use it in one case. And it actually makes the procedure very simple. But the only problem is the cost as of now. The cost is really high. Sometimes the IVL balloon itself would cost, will be more than the cost of angioplasty. So that's there. Dr. Arvind has another question. How do you manage an underinflated stent done by someone else outside, and it is a balloon undilatable lesion and the stent was put in? And that patient comes to you. How are you going to manage that? Of course, when he asked this, maybe I'm sure the person concerned must have dilated with high pressure balloons or an open balloon. But how would you manage such patients? And sometimes we are also tricked in our lab when we keep dilating and dilating with very high pressure balloons, and still we are not able to, expand the stent very well. So how do you manage in terms of how do you manage in the cath lab, and how do you manage in terms of antiplatelet or triple therapy and duration of the ability?
I think if the other person has not dilated with OPN balloon, then OPN balloon would be an excellent choice because they can go up to 40 atmosphere and even higher, and many times you can dilate it. And the key thing is repeated dilatations. So dilate it, then deflate the balloon, redilate it, go on doing it repeated dilatations many times helps. Another option would be a cutting balloon. Cutting balloon can be used. We have used it cautiously. What it does is that it cuts the tissue a little bit between the struts of that under-deployed stent. And that, after that, once you cut that and change the compliance, you can go in again with a high pressure balloon and the stent may expand. It has happened to me 3-4 times in past. Regarding rotablator, as you know, that rotablator is not recommended in such situations, so that is out. Regarding shockwave, again, right now it is not recommended, but I am told that some people have tried it. I have never tried it.
And the question of DAPT and the choice of DAPT, because these sort of underdilated stents, although they may be opposed to the atheroma, would be a big, substrate for stent thrombosis and restenosis in future, mainly stent thrombosis. So, how long would you continue your DAPT? What would your choice be for DAPT, and whether you would consider low dose rivaroxaban in combination with aspirin in these patients?
I think I would. I would go for high-end DAPT, that is the prasugrel and aspirin, or ticagrelor and aspirin.
LED, non-infected LED. And the stent didn't expand at all in spite of all these balloons. I didn't have that time this high pressure balloon, the OPEX that is available now, but I tried everything. Twice I tried. Still, it was dumbbell shaped stent. It was in LED, and it was quite frightening. So I recommended this patient to go for surgery, bypass surgery, because it was a major vessel. But the person never went. And I went on giving dual antiplatelet, hoped it will not cause any problem. But he didn't have any problem. Luckily, he died of some other things, not because of heart. But I'll still recommend, if there is a undilated stent which is not expanded, which is in the main artery, I think we should give the patient the choice of surgery.
Absolutely, absolutely. If the patient, if such a stent is there, which is underdilated and underexpanded, and you are not able to dilate it, you should think of surgery. Absolutely, because it's a potential time bomb. Another thing you could try, if you don't have even access to cutting balloon, you can put 2 or 3 wires inside and take your high pressure balloon down there. Those wires should not be hydrophilic, and then you can inflate the balloon, so that when balloon expands, there are 2 or 3 wires by the side of the balloon, and then they can help in changing the compliance of the lesion.
Yeah, you can also use 2 small balloons. That also have been tried. Many tricks like cutting balloon. There is no definite. These are all off-level indications. But it may work, may not work. But if it is not working, I think it's better to recommend surgery for this type of patients.
And always remember, when you are using these high pressure balloons, when you are trying these undilatable lesions, these vessels may rupture. So be ready with a covered stent in your lab. Be ready for pericardiocentesis. All those things must be ready in the room so that you don't lose the patient if the vessel ruptures, if you have that unfortunate incident.
If the vessel you have stented, which is stent is undilated, unexpanded stent, and you are using a high pressure balloon, and the balloon ruptures, there is perforation, and you put a cover stent, but the unexpanded stent remains there, then after that you have to send the patient for surgery.
Absolutely, absolutely. You just save that moment, and then send the patient for surgery.
The emergency.
what is the role of low dose rivaroxaban with aspirin in such patients? Because there's a lot of data now that this may be the way forward.
I don't know whether, as I said, prasugrel and aspirin or ticagrelor and aspirin is better, or low-dose rivaroxaban and aspirin, or low-dose rivaroxaban and clopidogrel is better. We need these cases are so unusual, cases of underexpanded stent, that it's a matter of conjecture rather than data. You have very low risk of thrombosis with all these therapies, rivaroxaban, ticagrelor, and prasugrel. So personally, I think there is very little to choose from. My whole focus would be into dilating these stents, and if these stents are not dilated, if it is underexpanded, I would send the patient to surgery, especially if it is in major vessel.
This is not very uncommon, especially if you are doing angioplasties on people who are 80s and 90s. Their vessels are calcified. Sometimes, you may not be able to expand the stent circumference, in 360 degrees. Very rarely, we have to leave stents which are well opposed to the wall, but, they are not substantially expanded. But what we have seen over a period of time, if you can achieve a good dilatation and keep dilating, and you have to keep dilating to a point when you are seeing dumbling. If the vessels are dumbling across, on the either side of the poor expansion, then that means that is the time you need to stop. And if it happens, our thing is that we follow these patients. Most of these patients with the newer stents do well. If you can have a mean area of more than 3.5 to 4, then I think they do well. But the only thing, we tend to keep these patients on not 6 months DABT, but at least 1.5 to 2 years DABT. Once they are endothelized, and then I think it doesn't matter whether it's fully expanded or not expanded.
Talking about repeated dilatation, I am reminded of one very strange case which was presented at one of the meetings, where the cardiologist brought in the patient 3 times in the cath lab. Repeated dilatations at a gap of a week each. This was right coronary artery, and he didn't want to subject the patient for CABG, rightly so, because his LAD and L6 were clean. And he brought in the patient every week. And on the 3rd attempt, the lesion yielded. It was very unusual. You don't do such thing, but that emphasizes the importance of repeated dilation.
Yes, I would totally agree. The vessel somehow sort of, it remodels, and the compliance changes, and maybe over a period of time it does dilate. And someday would be a better day, and you can actually be able to dilate these lesions. I'm not sure whether instead of one, we have tried, buddy balloons, also 2 wires, 2 balloons inside that stent. Sometimes it sort of works, sometimes it doesn't. We've also tried buddy wires with a balloon, 3 wires with a balloon, and as you said, cutting balloon. Yes, cutting balloon, gives you surprises in these sort of situations. It could be a proper. It's good to try EVL in such cases because especially in calcified, it may work because EVL penetrates quite deep inside the vessel wall and into the adventitious. I believe there is a question from. For the use of IVL, how we should size the balloon in regards to the vessel diameter. I think that is a standard. We use 1:1 sizing here, and both in coronaries and peripherals, and that's how the EVL, the EVL balloon is sized. But what is important here is you have to keep using it till the lesion starts expanding. It's not 1 or 2 cycles, but you have to finish the. Depends on how many cycles are there in that balloon, but you may use it till you exhaust all the cycles, pulsing cycles. wants to ask which cutting balloon is the best and how to use. Do you want to use a 3-blade cutting balloons or an angiosculpt? What is your choice, Dr. Samir?
Sorry?
How do you choose a cutting balloon? Which cutting balloon would you use? Would you like to use the standard 2-blade or 3-blade cutting balloon or an angiosculpt?
Standard 3-blade cutting balloon. Larger cutting balloons are there with 4 blades, but the standard up to 3.5 size, they use 3 blades. And we have only one cutting balloon available with us. We don't use angiosculpt anymore or scoring balloons. They are not easily available also, and they are not as effective as cutting balloon. So it's very important when you're using cutting balloon to size it properly, because in case you use a larger cutting balloon, you have the risk of perforation. So when you are using cutting balloon, be very careful, size it 1:1. And well, you can go higher pressures, but once you open fully with the cutting balloon, we generally do not go beyond 10 or 12 atmosphere.
I think there is some internet issue. Let me connect with Khanna sir again.
Yeah. Anyway, I think
yeah, we are. Yeah, I'm just connecting with sir and. I think we are not able to connect with Khanna sir. So we have addressed most of the question. So on the behalf of MQ Pharmaceutical, hello, okay. We have lost the connectivity to Khanna sir. So we have addressed most of the questions that we have received. We are very happy to share with you that. Yeah. Yeah. Hello, I think, okay. So we have lost the connectivity with Dr. Khanna sir. So we have addressed almost all the questions. So let me, I'm pleased to tell you that we have almost 1,500 audience across the country who are participating in this program, and we have received many questions from them. So on behalf of MQ Pharmaceuticals Limited, I thank you, International Course of Excellence, for endorsing this program. Also, I thank you to our eminent faculty for their interesting case presentations and very lively and interesting discussions. So through which we could even reach to 1,500 specialists across the country, and more 300 interventional cardiologists have participated outside the country. So at the same time, I will extend a thanks to our course director, Dr. Narendra Khanna sir. So today we will take a break and we will be joining day after tomorrow, that is on Sunday, 24th of May at 5 p.m. for the second set of this workshop. So we have 4 set of workshop every alternate day. So today's first workshop. So we will be catching up on 24th, that is Sunday, on 5 p.m. So thank you very much for everyone for their active participation. Thank you, Dani sir. Thank you, Raj sir, for being a part of this program and having a very inquisitive discussion, which takes this program to at a higher level. So let's meet up on Sunday at 5 p.m. and let's take a short break till Sunday. Thank you very much.
thank you.
Thank you.